The stigma attached to mental illness is slowly changing, but it is pervasive and prevents some from seeking treatment. And because untreated illness is one of the major drivers of suicide, the stigma must be fought with urgency. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, Senior Writer for the AHA. Today, AHA Senior Vice President and Chief Medical Officer Dr. Jay Bhatt and Dr. Jerry Reed, Senior Vice President for Practice Leadership at the Education Development Center, discuss the causes of physician suicide. What role might family members play? How can physician traits such as perfectionism lead to ultimately taking one's own life? Their guest is Dr. Michael Myers, Professor of Clinical Psychology at SUNY Downstate Medical Center in Brooklyn, New York. Dr. Myers is the author of 8 books, including Why Physicians Die by Suicide, Lessons Learned from Their Families and Others Who Cared. Let's join their discussion.
Welcome, Dr. Myers, and thanks for joining us today. We are so grateful for your work and your time, and look forward to the conversation.
Well, thanks very much. I'm delighted to participate in this podcast with both of you.
Great. To get us started, Dr. Myers, can you please tell us a little bit about yourself and your interest in the topic of physician suicide?
My interest, unfortunately, is rooted in tragedy. It goes back to 1962. I was a first-year medical student, and I lost one of my roommates, another first-year medical student, to suicide over the Thanksgiving weekend of that year. And that was awful. That was a long time ago, but yet in many ways it seems like it was just recently. Nobody saw it coming. I was one of the last people to see him alive. I was only 19. I'd never been exposed to anything like this before. I had no idea at the time, of course, that Bill's tragic death would project me into a lifelong sort of interest in physician health. And I didn't go into psychiatry right away. After I graduated from medical school in 1966, I did a rotating internship, which was common in those days. And then I worked as an emergency physician for a year. And then I did a year of internal medicine residency. But it was my exposure to so much suicide during my internship, as well as in the emergency room where I worked in Detroit, and then also internal medicine, especially in the intensive care unit, that actually attracted me to psychiatry. So when I finished my training in 1973, I embarked on a 35-year career of half-time academic work and half-time private practice. And it was through my private practice, where I began to look after quite a few physicians and medical students. And so therefore, for the last 20 years of my private practice, I restricted it to only looking after physicians and their family members. I treated a lot of suicidal physicians in my career, and unfortunately, I've lost a few physician patients to suicide.
Dr. Myers, thank you so much for sharing that personal experience and story, and we are so glad you are in the field with us on this issue, and grateful for your contributions and service. So just to build on some of what you shared, can you talk a bit about the epidemiology and the etiology of physician suicide, how it shows up?
Yeah, I'd be happy to. With regard to the epidemiology, unbelievably, we don't have good data. But at another level, it's hard to study something that is so stigmatized in our society. What has been learned through the American Foundation for Suicide Prevention is that 300 to 400 physicians die by suicide each year in the United States. However, having talked with Dr. Christine Moutier, the Chief Medical Officer of AFSP, because they're not really sure about what's really happening with regard to epidemiology, they're no longer having that on their website. But what we don't know is whether or not the numbers are increasing or whether they're decreasing, as we've recognized this and have done so much in terms of prevention. But one thing I can tell you is that it isn't going away. We wonder sometimes if the numbers are going up like the rest of the population, because we know the rates of suicide in this country have been increasing steadily for the last 25 years. So we don't know so much even about other countries. The male rate of death by suicide is higher than men in general, and the rate of death for women doctors is actually much higher than women in general. We're not exactly sure about this, but I'll come to that in just a minute. People often ask about specialty. A lot of this is more conjecture than anything, but yet because of some studies in the United Kingdom, it's felt that there are at least 4 groups that perhaps are a bit more prone to death by suicide, and that's anesthesiology, psychiatry, primary care physicians, and something in the UK called community physicians. With regard to the age of physicians, we know that there are certainly a complement of medical students, residents, and fellows who die by suicide each year, especially women. We're not exactly sure how that translates into the fact that suicide in that stage of the life cycle, younger people, is at a higher rate as well. It's known that teenagers and people in the early 20s to late 20s are the second highest rate of suicide deaths in our country. So that would include some people who are studying medicine. But then also physicians in their middle years have a higher sort of rate of death by suicide then as well. And that corresponds to what we know about death by suicide in the general population. We have no data on race or ethnicity of physicians. International medical graduates, it's believed, may actually have lower rates of death by suicide, and whether that's got something to do with the fact that many of them have a lot of family of origin supports, which a number of American graduates don't have, and they tend to have less financial indebtedness than our U.S. medical school graduates. So let me turn now to your question about the etiology of physician suicide, because that's also complex. In a sense, we don't have a typology, but there are at least some sort of types of death by suicide in physicians. You perhaps could call these templates. The one thing we do know is that for some physicians who die by suicide, there's been a confluence of factors that have overwhelmed the person in what is called a perfect storm. And of course, I mean that in a perfect, horrific storm. So these are factors that are descending on the individual all at once. And we're not unique to this. This can occur, in the general population as well. But certainly there are some physicians where there's all of these factors coming together at once. And then others, and some of these are physicians who have died in my practice, are the ones who have been dying with what we call a malignant form of a psychiatric illness. And that's like the general population as well. Those are individuals who are no longer able to practice medicine, for instance, because of the gravity of their illness and its relative lack of treatment response. And then there's another group of physicians who we think fit into the category of rational suicide. And those are more often physicians living with terminal, often progressive neurological or medical disorders. And these are individuals who have very progressive ideas about rational suicide. And some of those physicians die by suicide each year. Let me just say something about the diagnostic categories. Certainly major depressive disorder, bipolar illness, post-traumatic stress disorder, substance use disorders, severe anxiety disorders, personality disorders, and chronic medical disorders are all factors, are all diagnoses that you can see in physicians. And like anyone, it's felt that can be one of the indirect causative factors in terms of death by suicide. We're reading a lot these days about burnout versus depression. There was a wonderful piece in the recent issue of JAMA Psychiatry. And basically what the thrust of that opinion piece is how important it is that we not miss, say, a diagnosis of depression by somebody who has labeled himself or herself having burnout, because there's so much overlap in terms of the symptoms. But we worry that it becomes a catch-all. and that therefore there are individuals who are actually not being diagnosed with depression and not receiving the proper treatment. And so it's very important that that occurs so that that category of individuals don't end up taking their own lives. And with regard to the stressors, of course, there are a number of professional stressors that we read about in doctors. I mentioned the indebtedness, which is severe in many of our medical students as well as recent graduates. Lawsuits, any investigation of a medical license. Sometimes when physicians are suddenly dismissed or fired, what we call in psychology and psychiatry a severe narcissistic injury. We're learning more about sexual harassment in our medical centers with the whole Me Too movement that's happening. We believe that there's a significant Me Too movement as well, especially for women in the House of Medicine. And then for our physicians who are members of racial and ethnic minorities, that's when we pull on things like microaggressions, micro-insults, micro-discrimination, and those types of things could be factors contributing to this whole confluence of factors in doctors. The personal factors, I don't think they're really any different than occur in people in going through life: a severe divorce, loss of family supports, health challenges, bankruptcy, all of those things that can, affect human beings. One thing I do want to say is about a lack of a proper diagnosis and treatment in physicians. We so easily fall through the cracks when we're in our hour of need. There's a lot of reasons for this, but one of the biggest is stigma. I've been working in a stigmatized branch of medicine most of my career, of course. We've done, I think, a better job of reducing stigma in the general public than we have in the House of Medicine. It's still better than it was, like in 1962 when Bill died, but we still have a ways to go. And so, especially the interior stigma, that's the so-called felt stigma that doctors feel, this internal shame when they fall ill. They feel less than, they feel apart from their fellow trainees or colleagues in medicine, and it's a terrible way to feel. And then, of course, there's external stigma, and this is basically discrimination. These are when questions that are asked on credentialing applications for our medical centers or for medical licensure applications. And I'm sure that most people are aware that there's a lot of effort now going out there to modernize applications for medical license. And in fact, there are some states, including the state that I work in New York, where no questions are asked at all about your health when you apply for a medical license. I think there are about a dozen states like that. But what we're recommending for those states who do want to ask something is this, or a variant of this: are you currently suffering from any illness that is affecting your ability to practice medicine safely and competently? And if so, please explain. Emphasis on current, and also emphasis on putting everything together and not partitioning off psychiatric illness, substance use, et cetera, et cetera. So we'll see how that goes. I think that there's a strong movement for that. I have found in my research that there are, and I'll say something about that a little bit later, so let me just hold that thought. And let me finish with just some other factors. I mentioned earlier the indirect drivers of suicide. That's an underlying psychiatric illness. The direct drivers of suicide is a very important piece of research, because what we've been wondering about for some time is, why do some people who are severely depressed never have a thought of suicide, whereas others, maybe even with less severe depression, begin to have thoughts of suicide very early? With regard to the direct factors, direct drivers of suicide, whether or not there are at least some physicians who have what we call a suicidal diathesis or tendency. And so those are individuals that are under study. And the final comment I want to make with regard to etiology is the so-called culture of medicine. There's still very much of a macho mystique in medicine. Again, it's better than it used to be, especially with so many women in medicine now over the last several decades. But there is, though, this ruggedness and this sort of autonomy and this denial of vulnerability in oneself that can really be problematic when physicians can't accept their humanness and their need to actually go and get some professional help. So it's seen as the smart thing to do, not as something that's shameful or week.
Thank you, Dr. Myers. You're absolutely right. The epidemiology and the issue is complex, and so really appreciate you laying that out for us in a way that we can make sense of. And so I'll turn over to Dr. Reed.
Thank you, Dr. Batt. Dr. Myers, I'd like to ask, since there is such a dearth of research and questions that we ask about physicians and physician suicide, you must have spent much of your career qualitatively talking to family members of physicians we've lost to suicide or colleagues themselves. And so I'm wondering if you could share 3 or 4 major learnings of what you might have picked up over the years from those who loved a physician who died by suicide or worked closely with a physician who died by suicide. Are there major lessons learned that you can share with our listeners about what you've picked up upon?
Yes, there are. And thanks for asking me that question, because that was the reason why I embarked on this qualitative research project now about 5 years ago, interviewing quote-unquote significant others of physicians, especially their family members who have taken their lives. But I extended that to also interview their roommates, to interview their professors, to interview their students, to interview their colleagues, to interview their therapists, and also I interviewed some patients who had lost their doctor to suicide as well. Some of the key findings are the following. I learned that roughly 10 to 15% of the individuals I've interviewed, which is now up to about 100, that their deceased loved one died without receiving any care at all. And I was really shocked at this. I mean, I know we fall through the cracks, but these are individuals who took their lives. In other words, they went from feeling well to feeling ill to death. And these are physicians. They didn't go to a primary care physician, a psychiatrist, a psychologist, the clergy, a therapist of any sort. Their family members often begged them to go for help, but for various reasons, they absolutely refused. And then next thing we know, they had died. So we have to do something about this, because I believe strongly that at least some of those individuals have died by treatable and untreated illnesses that were just never diagnosed and recognized. There's another cluster, too, that I've learned through my research, and these are physicians who did go for help, but the help was woefully inadequate. Usually an underdiagnosis by the treating person who was perhaps inexperienced in looking after doctors, misdiagnosed, as I say, underdiagnosed and therefore undertreated. So where the individual didn't realize that this doctor is really suffering and is really at risk of self-harm. Now, I'm not putting that just all on the treating personnel. It also has something to do with us as physicians when we become ill. That for various reasons, sometimes we don't make the best patients. It's our busyness, it's our fear, or whatever. We hate being in the patient role. And therefore, some doctors have a lot of difficulty adhering to the recommended treatment and actually committing to treatment. Again, that's rooted in stigma too. They just want the illness to go away rather than wait it out and get evidence-based treatment. The third thing, of course, which I talked about extensively a few minutes ago, has to do with stigma. And certainly the family members had really, really felt that. And what they included with me is a judgment piece, that they felt that their ill loved one was sometimes shunned by his or her medical colleagues, and that was very hurtful for their physician loved one to experience. When I spoke with kids of women physicians who had taken their lives, or husbands or partners of women doctors, many of them have felt that there's been a gross underappreciation for the huge role strain of women in medicine. When you think of it, yes, these are not only busy women professionals as physicians, but they are also most oftenly the CEOs of their home. Even in dual career and egalitarian marriages, most of the finest husbands are sharing sort of in the workload with their wives, but the actual CEO, the administrative responsibility for the home, is this unpaid and unrecognized and sort of, very important role of the woman. The other thing, too, is that there are many women physicians, and this is where the Me Too movement comes in, and especially in the face of sexual harassment and micro inequities, that these women have not always felt supported by their male friends and colleagues in medicine, that they've either had to do it alone or strictly with their women physician colleagues. And there's an imperative there for we men in medicine to recognize this and to assist and fight for change. Some women are terrified to seek professional help. And I get that because I trained in medicine back in the 60s at the time when women in medicine were really not very welcome. Many of them were made to feel that they were taking up the place of a man, and they better be good, and they better not have any flaws or blemishes. So, I realize that's a long time ago, but I think there are vestiges of that still in our medical colleges. And the final thing about women in medicine is the right kind of help available for them. Are they really getting gender-sensitive care by the treating professionals whom they go to see? So, Jerry, in response to your question, those are some of the findings that I think are really very important. Oh, and finally, too, what I have found is that these individuals are so willing to get involved in some way that they have lost a physician loved one to suicide. Many of them want to speak to classes in medical school or at medical meetings to tell their stories. They want to make a difference, and they will say, too, that by doing that, they feel that their deceased and departed loved one will not have died in vain.
Thank you, Dr. Mars. And I can tell you, you know this from having worked with me in the past. I've met many of these survivors of loss who've lost a physician, loved one, and you're absolutely right. They saw a perspective from the eyes of a loved one that, is so informative to helping us get it right as we move forward and creating a just culture and engaging the voice of the lived experience so we can better look after the physicians who struggle and recognize that in many cases there's a veil of secrecy over the open conversation, which thankfully, due to you and others like you, is beginning to lift in the practice of medicine. So thank you for that comment, and I'll turn it back to Dr. Beth.
Thank you.
Thanks, Dr. Reed. Yeah, and I'm really struck by how challenging it can be to lift that veil and to help address some of those issues and be forthcoming and get help. So thanks for sharing. Speaking about some of the comments you made earlier tied to this recent discussion, are there unique risk or protective factors involved with physician suicide? So can we get out in front of it and try to help?
Yes, thanks, Dr. Bond. I've thought about this a lot, actually, and I and others who work in this field have thought about this too. The one thing that stands out for us in medicine, of course, and not just us in medicine, there are other people with this kind of training, is our knowledge of toxicology. So in other words, we begin to learn in medical training, in biochemistry and physiology, some of the toxic and noxious chemicals. Some we learn a lot in pharmacology about medications that can be dangerous in overdoses or cause particular side effects or things like that. So there's that kind of sort of biomedical knowledge, and then the access to means. We do have access to many drugs, and especially hospital-based physicians, intensivists, anesthesiologists. We know that they have access to narcotics, especially something like fentanyl. Intensivists have access to potassium chloride, which is used in some deaths by suicide in doctors. Some of the other factors that put us at risk is our perfectionistic personality. Now, again, we don't own this, like in terms of a monopoly, but yet our perfectionism can be our undoing. As you know, this is a double-edged sword. We have to have a certain measure of perfectionism to even get into medicine and to thrive and to do well. But when it's hypertrophied, when one's perfectionism is a capital P as opposed to a small p, these are doctors who are very hard on themselves. And they can be very hard on themselves if they fall ill as well, and that could put them at risk of self-harm. We think that this is ill-defined, but there may be a cohort of physicians who are the so-called superstars. These are physicians who are the elite in medicine, who have unbelievable pedigrees in terms of their academic credentials. When and if these individuals die by suicide, these are the deaths that are always so shocking to not just their colleagues, but to the general public. And we wonder, is there something there that we're missing? There's a sensitivity. Sometimes doctors with narcissistic personalities have a lot of trouble coping with assaults or losses in their lives, and perhaps they could be at risk. And then finally, I want to mention the fine work of Dr. Thomas Joyner, very illustrious psychologist in Florida, who has come up with a triad of vulnerability for people in general. But one of the triads is, quote unquote, learned fearlessness. And even Thomas Joyner himself has speculated or wondered as to whether or not, because physicians are so exposed to death, and also some of them can be risk takers, could that actually be a risk factor for physicians in general? I want to mention the protective factors because they're not to be made light of. Overall, doctors are known, despite the fact that, yes, we get burnout and stuff like that, but overall we're defined as a pretty resilient group of human beings, a pretty resilient group of citizens. So generally our resilience is usually high, meaning that we can bounce back from stuff and, survive and grow and et cetera, et cetera. Many of us have the financial means to pay for therapy or to pay for a treatment center if necessary. We have status and respect in the community, and that can be a protective factor as well to sort of keep us sort of maybe feeling better about ourselves. And then just other things have to do that maybe there is some flexibility that if it doesn't work out in one medical center, then, we have our medical license. We can go to another place, or we can go perhaps into a different branch of medicine. So those are just a few, of the protective factors that serve us well in our hour of need.
Thanks, Dr. Myers. I think those are wonderful insights that we can draw from. And turn over to Dr. Reed.
Thank you. Dr. Myers, I'd like to kind of follow up a little bit on that and talk about the protective factor of connectedness. And so I'm wondering if you can describe a little bit, how can a healthcare system better support their physicians or other staff who might be at risk for suicide? What can colleagues do if they suspect someone they work with is thinking about suicide? How can they be proactive and help guide that colleague to a connectedness component that a system may have set up or may exist externally?
Thank you, Jerry. And I'm glad you've used the word connectedness, because we know from certainly so much of the psychology literature what a health promoting and health protecting factor that is, connectedness with others. With regard to our system, I thought about this a lot, actually. I'm making a suggestion, and I've been talking about this more in my lectures, that we adopt the HIV/AIDS model of universal precautions. I remember when that first came out back in the early years of the AIDS epidemic, and then before it became a pandemic, that we need to work from an attitude of universal precautions. And I say that because it's not easy to identify high-risk people just like that. It's not like they walk around with a badge, I'm high risk. And again, because of what I said earlier about stigma. And this connects with your comment about connectedness. So we don't know who might be at risk of suicide. And sometimes they don't know either, including physicians who have attempted suicide in the past. They may not know that puts them more at risk of a second attempt, that sort of thing. Okay, so that gets us to things like a healthy and wholesome workplace, which is absolutely essential, where there's buy-in right across the board, especially at the top. We need to keep emphasizing and re-emphasizing that burnout is not normal. It's caused by toxic work conditions and can afflict the healthiest of people. We need to listen carefully to what healthcare professionals themselves, not just doctors, but nurses and all other kinds of health professionals, what they want and what they feel they need in the workplace. They need a voice. I believe, I've been around a long time, and I felt for too long healthcare professionals have been treated as workhorses. especially physicians, because we're sort of known as hard workers. But it's really only been the last decade or more that we've known more that this is affecting us. It's making us sick, when you see so much stuff about burnout and that over the past 10 to 15 years. Many physicians feel, and they will admit they feel they've paid a price for that. So I think it's very important that their altruism not be exploited. We need things like flex time, maternity leave, paternity leave, parental leave, caregiver leave. We read and hear so much about electronic health records, electronic medical records. I know that there's efforts being made to make those more user-friendly or to make them sort of more streamlined or so that they're more for patient care and not for, not for financial reasons. The ethos of caring. I think when a medical center, no matter how big it is, and it's beyond the mission statement, says that we're one big family here. Where I work, it's called the downstate family, and it starts from the president down. Then the other things, of course, that you hear about and read about that are being instituted in many medical centers across the board are these health-promoting things like healthy food, yoga, meditation, having pictures up, music, parties, things like that. And then finally, it's got to do with reaching out to a colleague in a kind and non-judgmental way. There is a very short 4-minute video that's been produced by both the American Foundation for Suicide Prevention and the Mayo Clinic. I was asked to be a consultant on this, and it's called Make the Difference: Preventing Medical Trainee Suicide. There is so much packed into that 4 minutes. It's available on YouTube as well as, of course, the respective websites of AFSP and the Mayo Clinic. But I use it not just for medical students and for residents and fellows. I use it when I'm talking with physicians who are way beyond their training years, because first of all, it is really about the responsibility that we have, not just for ourselves, but for each other. And it walks you through what to say and how to reach out to another person and what not to say. It's a very collective, and to get back to your words, are a connectedness type of product. And that's just one. There are others out there as well. But those are some of the things that I wanted to just sort of share with you in response to your question. Thank you.
Thank you, Dr. Myers. Dr. Batt?
Thanks, Dr. Reed. Dr. Myers, why do you think this profession is particularly prone to concerns about suicide?
Well, at one level, and I don't mean to sound glib or flip, I think it's a no-brainer. In other words, if you're a physician and if you're not concerned, I don't know if you should be in medicine. Because isn't it one of our principal tenets of being a physician to help people, to treat others, to treat people with illness, and to protect life? This is why there's this kind of huge sort of paradox or irony, and especially the general public when they learn about physicians dying by suicide, because they see us, and I think we see ourselves as individuals who have been drawn to medicine to protect life, to preserve life, to care for others. And some of them, I even had one person say to me, when a physician kills himself or kills herself, that's pretty scary, because if they've given up, then what's it say for the rest of us? Because, as you know, we are seen as those individuals who are there to help others. And so therefore, when we lose one or more of our own, it can't help but affect us very, very deeply. And that's why I find it very gratifying, first of all, to be participating in a podcast like this, and also to know that increasingly, not just the House of Medicine, but even the general public are concerned about us, our well-being, and our ability to thrive and to do well, and then to obviously be available to them, to be good doctors who are fulfilled by our work. and feel gratified, by that.
Thanks, Dr. Myers. I think you're right that the public and physicians alike are recognizing this as a critical issue, and I think we're seeing it among non-clinical leadership in hospitals and health systems as well, that they want to take an active role, in partnership with clinicians to address this issue of burnout and driving resiliency and well-being. Dr. Reed, would you offer some additional comments here?
Thanks, Dr. Brad. I would just offer two pretty personal comments. Having been in the field of suicide prevention for about 23 years now, and prior to that working on behalf of our soldiers and their families overseas with the Department of Defense, and doing this mental health work and substance misuse work for the U.S. Army overseas, I remember as a young practitioner just out of graduate school and it's such, asking myself the question, who cares for the caregiver? I felt there was just so much emphasis on doing well, serving the soldier, serving the family, whatever, that we often fail to have a conversation about self-care and about caring for the caregiver. And so I'm really moved by Dr. Myers' comments about, caring for physicians and appreciating the contribution they make to the health of the nation, the health of the world, frankly. And having just seen my own primary care provider this morning, I'd be remiss if I just didn't say, and I've said to him many, many times, thank you so much for just being such an integral part of my life for the last 30 years and in my children's lives, et cetera. And I think it's really important to the listeners and those on the call, every now and then it doesn't hurt to say thanks for the care we receive and the commitment that our practitioners make to our health without, very rarely anyway, being asked about their own health. And so, that can be a lonely position at times. And I really am grateful to Dr. Myers and to yourself for giving us the platform to have this conversation today, to both thank our practitioners, but also ask them to please look after yourself. And if you're carrying a burden that is extraordinary, step forward and get the help in a caring, connected system that you've earned the right to have so that you can return in a great phase and continue to practice the great medicine you've been trained to practice. And thank you again, Dr. Myers, very much for your time.
Well, thanks very much, for inviting me to do this and also to facilitating this just so nicely. It's made it a very sort of rich and comfortable experience for me.
Dr. Myers, thank you so much for your comments. I think they resonated with both of us and resonate with our audience. What is the issue? What can we do about it? And how can we collectively work together to address it? And I think addressing the stigma is critically important, and creating a community of caring so that we have physicians for our communities in the ways they need them most is really important. So thank you, Dr. Reed.
Thank you, sir.
Thanks so much for all that everyone is doing on this issue, and we look forward to checking in with you next time.
Like anyone else battling depression and or mental illness, doctors need to know that they are not alone, that help is available. Thanks to these three physicians for tackling an uncomfortable subject and offering hope. This has been Advancing Health, a podcast from the American Hospital Association. Thanks for listening.